Anyway, welcome in this last day of our conference. We have a completely different setting compared to the first 2 days. More cozy, I think. But anyway, we'll have our final day today, and we have a very interesting program, I think. We'll focus in the first session on various subdisciplines like surgery, imaging, etc. Go into depth there. And then we'll also have a special session on a special category of patients, the young adults and adolescents, which I think is very important to consider as a special session. They have their own wishes and their own problems. And we have a session that focuses on the empowerment of patients. We will hand out the special awards that we have for very valuable activities and things that our member organizations have developed and that can be of interest to other patient organizations to learn how we can best develop our patient advocacy groups and how we can empower the patients. The first session will be chaired by Estelle Estelle Artzner from France. Where is Estelle? I was looking over your head. I am so sorry. I'm so sorry. So please, Estelle, take over and chair our first session.
Thank you. So good morning, everyone. Welcome to the session dedicated to the impact of treatment on research and research on patient outcomes. So as to start this last day, we are going to have a great panel of 3 American experts that are going to present the key innovative developments from the fields of imaging, surgery, and radiotherapy, and which can be offered to patients beyond systemic and medical therapies. As far as the organization of the session is concerned, we're going to start with 3 presentations, and then we'll keep the last 25 minutes for questions and discussion. So please don't forget to write your questions, because I see that you seem to appreciate your breakfast, but don't forget your question. So I would like now to invite our 3 medical experts to join me on the stage. Dr. Eva Dombi. She's a radiologist from the NCI and leader of the PET section imaging program at the Center for Cancer Research. Dr. Kurt Weiss, I'm sorry. He's an orthopedic surgeon, associate professor specialized in the treatment of musculoskeletal tumors, both in children and adults at the University of Pittsburgh. And Dr. Ashleigh Guadagnolo, radiotherapist and professor and section chief of the Sarcoma melanoma radiation oncology section at the MD Anderson in Houston. So thank you for all being with us today. And now I shall immediately give the floor to Dr. Dombi. Thank you.
Good morning, everybody. I'm delighted to be here. My name is Eva Dombi. I do imaging-focused research at the Pediatric Oncology branch of the National Cancer Institute. I have to make a correction. I work very closely with radiology, but I'm not a trained or certified radiologist myself. I will be talking about advances in the detection and monitoring of sarcomas. I picked 3 topics for today. One is the detection of malignant transformation in neurofibromatosis type 1 related peripheral nerve sheath tumors. Then move on to assessing tumor response to therapy in clinical trials and closing with the development of a tumor burden score to characterize the overall burden of disease in clinical trial patients. When a mass is suspected, some type of imaging is usually ordered, be it MRI, CT, or PET. By no means are these the only imaging modalities, but the most frequently used. Each of these have advantages and disadvantages. MRI is particularly powerful because it's very versatile. Different sequences can be obtained and optimized for different tissue types. It is best for soft tissue tumors, and the disadvantage is that it takes a very long time to obtain the imaging, sometimes over an hour. In contrast, CT is very fast, hold your breath and it's done. It gives superior detail of the lungs, the bones, and some internal organs, but it exposes the patient to ionizing radiation, which is a disadvantage. PET scan is a type of functional imaging that uses a tracer molecule that accumulates inside or around specific cell types. The one example I'm showing here is an FDG PET. It's a glucose-based, commonly used tracer that accumulates in fast, rapidly dividing cells. Usually it's used in combination with CT for anatomic localization. The patient in the example has neurofibromatosis type 1 and a very large paraspinal mass that on the MRI you see as a round kidney-size mass next to the spine that is bright on this particular sequence. On the CT you see bony destruction or erosion in the spine. On the other hand, the PET scan doesn't show any tracer accumulation, and that suggests a low-grade lesion. A little background about neurofibromatosis type 1. It's a genetic tumor predisposition syndrome with incidence of 1 in 3,500 people worldwide. People with NF1 develop tumors along the peripheral nerves called peripheral nerve sheath tumors. Dermal tumors affect almost all patients and never turn malignant. A type of complex tumor along peripheral nerves called plexiform neurofibroma affects up to 50% of individuals with NF1. Occasionally in these tumors, additional mutations accumulate and the cellular structure changes, and these became atypical neurofibromas. We don't really know the incidence of these tumors, and a fraction of them eventually transform to malignant peripheral nerve sheath tumor, MPNST for short. At the NCI, we had a long-running natural history study to evaluate the evolution of different manifestations of NF1. The participants underwent regular whole-body MRIs. Among the patients who had internal plexiform neurofibromas present, a large proportion also had what we call distinct nodular lesions. These are large, encapsulated, solid-appearing masses that are structurally different than the normal plexiform. It's rare to see these larger distinct nodules in children, but the prevalence increases in the teenage years, and in some cases we can follow one particular small nodule gradually increasing, and some patients, as the example here shows, develop multiple lesions like that. From the natural history study, we learned that the growth rate of benign plexiform neurofibromas, a typical multi-branching tumors, correlate with age. And in adults, we rarely see significant increase, while in younger patients, they may grow more rapidly. On the other hand, the distinct nodular lesions don't show this age relationship and can have very high growth rate even at any age, basically even in adults. We also observed that when we performed the glucose-based PET scan, increased metabolic activity is localized just to these distinct nodular lesions, and in regular plexiform neurofibromas, you don't see accumulation. In a retrospective study, we looked at 35 MPNST cases, And in the vast majority, over 90% of the cases, we could see a pre-existing distinct nodular lesion on MRI several years before the MPNST diagnosis. And this combined data suggests that these distinct nodular lesions and not the typical plexiform neurofibroma are the direct precursors to MPNST. The problem is that distinct nodular lesions, as I mentioned before, are very prevalent, and only a fraction of them will turn malignant. And unfortunately, neither the growth rate nor the PET avidity clearly indicates the malignant potential. So we are looking at a different imaging technique, diffusion-weighted imaging with apparent diffusion coefficient mapping. Dr. Laura Fayed at Hopkins was the first to apply this existing technology to peripheral nerve sheath tumors. It is able to detect water molecule movement, and it's used for other type of tumors, especially brain tumors, but it hasn't really been used before for peripheral tumors. What you see in the upper panels is different size and different locations of these distinct nodular lesions in anatomical imaging. And the grayscale image below is a calculated estimate of the water molecule movement. Bright signal indicates free movement of water molecules and therefore low cellularity, and darker signal suggests restricted water molecule movement and higher cellularity. The patient in the far right panel was diagnosed with high-grade MPNST soon after this MRI. And what is important in that respect is that seemingly the anatomical imaging is identical. We don't really see any other concerning features in that particular nodule that would suggest malignancy, and even the size is so small that it's not a suspicious tumor, but with the addition of this technology, we were able to detect malignancy early. Definitely, the question now is, can we see a trend and identify not the high-grade tumors, but the tumors that are on track to become malignant at an early stage when surgery is generally more feasible. We have a newly opened study with the goal of evaluating, in other things, the role of diffusion-weighted imaging for this tumor type. So this is about the subject of NF1, and then I move on to response evaluation criteria in solid tumors as used in clinical trials. What you see in the image is a large tumor mass that is fairly round, easy to see, and over time you can do a line measurement and estimate the change. The first time the unified response criteria was proposed, the goal was to have a method that is simple enough that everyone can report clinical trial results the same way, and therefore the trials are objectively comparable. The era when the methodology was first suspected was highly focused on cytotoxic chemotherapy, and the expectation was that with high levels of toxicity, you want very robust responses. And intentionally, it's not a very sensitive method. It's easy to do, it's easy to compare, it's statistically a beneficial methodology, but applying it to the modern era where we test much less toxic components or drugs, we need more sensitive measures, because if we apply this very high expectation of response, we may call agents that are beneficial, clinically beneficial to the patients, actually inefficient because they don't meet the standard for response rate. One way to get better and more sensitive measurements is moving to volumetric analysis of tumors. What you see here is a complex shaped tumor, and if you apply the line measurements, they register stable disease. The cutoff for progression would be 20%. So it says there is no change in this tumor, but visually you see there is obviously increase. I hope you agree. When you outline the tumors and account for the entire tumor bulk, the increase is readily visible, like 100% increase is doubling of tumor bulk. So you have much more sensitivity. In fact, if you look over time, small incremental changes in a complex tumor like that can be easily detected. This methodology has a role mostly in complex tumors that are slowly growing, but I would mention that it does have benefits for the sarcoma world. The FDA approval of the gamma secretase inhibitor for desmoid tumors has been mentioned at this conference before, but I would add to that success story that volumetric measurement did play a role there. When Dr. Kumar designed the phase 2 clinical trial, she added an optional MRI scan to look for tumor volume change over time. The response rate was 5 out of 17 patients by standard response criteria, which is not a stellar, exciting result in many sense. Similar response rate drugs fizzled out in clinical trials, but with the supporting evidence that 10 out of 11 patients who underwent the volumetric analysis showed very dramatic responses, was able to generate the excitement to move this drug towards a phase 2 study and the success of approval in 2023. Another approach to look at different quantifiable features of tumors was proposed by Dr. Choi and her colleagues when they observed that patients who have gastrointestinal stromal tumors and receive imatinib treatment have better outcome, long-term outcome, if they show metabolic response on FDG PAD. Here you see a very large mass showing significant uptake, and at follow-up, the uptake is completely gone, although the tumor itself actually looks bigger. What they observed is that the tumor became cystic and necrotic, and they also could prove that measuring the density, which is a very straightforward, simple measurement out of CT, the tumor density is decreasing. So instead of using the very expensive and radiation exposing PET scan, they are able to detect change in tumor density. And for this patient, the change in tumor density would qualify for response even though the size hasn't changed. The response criteria defined by Choi and her colleagues is either 10% reduction in size, meaning the longest diameter, or 15% reduction in tissue density measured of the CT. And progressive disease would be 10% increase in the size, but only if there is no response qualifying reduction in tissue density. Similar criteria has been adopted to other diagnoses and also for the use of MRI instead of CT. The final topic I would like to address is our effort to develop a disease burden score for clinical trial participants. Early phase clinical trials often enroll a heterogeneous cohort of patients, and you can see on these PET images the wide range of tumor burden between the newly relapsed patients and the multiple refractory and advanced disease. The overall disease burden may influence the response to treatment, so stratifying for analysis is crucial. And that's why Dr. Rosie Kaplan at the POB proposed this very simple scoring system that takes into account the size of the largest tumor, the number of metastatic lesions, and the number of disease sites involved to come up with an overall disease score that can be correlated with response. This work is still in further development, but she was able to successfully apply this in one of her published studies for Ewing sarcoma patients. This is, as I said, still in progress, and we will see if it helps move the science forward. Thank you very much. And
all right, thank you. Good morning, everybody. While they're bringing up the slide deck, my name's Kurt Weiss from the University of Pittsburgh. I'm a sarcoma survivor, a sarcoma surgeon, and a sarcoma scientist, so I wear a few different hats in this space. And I'd like to talk to you this morning about using indocyanine green fluorescence angiography, fluorescence imaging for detecting margin status in soft tissue sarcoma surgery. We have some friends from the UK. My buddy, my good buddy, Kenny Rankin at Newcastle is using a similar technology to look at margins in bone sarcoma surgery. Okay, cool, thank you. You will see that, so unfortunately for you, I am not the beautiful, brilliant, and amazing Dr. Rebecca Gladdy, who was originally going to give this talk, but I'll do my very best in her absence. She has been a wonderful mentor and colleague to me. The dye that I got for the study you're about to see is the gift of Stryker Endoscopy. I am not a Stryker consultant, paid or unpaid. I don't speak for that company, and they don't speak for me. And finally, I did want to mention that different parts of the work you're about to see was supported by both Sarcoma Foundation of America, the table back there, and also by the Connective Tissue Oncology Society. So thank you for everybody who helped to make this possible. I have, in my opinion, a real nice mouse model of metastatic osteosarcoma. My research interest is in sarcoma metastatic potential. And I have this wonderful model of immune-competent pulmonary metastases from osteosarcoma, except that I didn't have a great way to measure the burden of pulmonary metastases. So I was in a tight spot, because if you're a metastasis guy and you can't measure metastases, you got problems. So in comes my resident, Mitch Foreman, who's now an attending in musculoskeletal oncology at Montefiore in New York, and he said, why don't you use indocyanine green dye? And I very intelligently asked, what the hell is indocyanine green dye, and why should I care? Well, this is a cyanin dye that was invented by the Kodak company back in the 50s for infrared photography. Never really took off in that application, but it sure took off in medicine, where my colleagues in plastic surgery, ophthalmology, breast cancer surgery are all using this. And once again, sarcoma is late to the table. But in any case, the molecule has a very narrow excitation and relaxation wavelength, which makes it pretty easy to detect with a detector. So how it works, in normal vasculature, the dye goes through your vascular tree, your blood vessels, washed through your hepatobiliary system and excreted in your poo. Very quickly, actually. But so in order for sarcomas to grow, they need to elaborate their own independent blood supply, right? Or else they wouldn't grow. Well, it turns out that the vessels inside the sarcoma are not of very good quality. They're leaky. So our hypothesis, the same thing happens with burns, obviously, because the vasculature is disrupted. So our hypothesis was that the blood vessels in the sarcoma are going to be crappy enough that the dye is going to be able to leak out and get trapped in the tissues, so now we can see it with the detector. And then something happened we did not expect, which was that it worked. And we used retroorbital injection, so we injected it behind the mouse's eyeball there, and you can see the beautiful tumor there in the left hind limb. And if a picture's worth 1,000 words, here's a movie for you. This is one of our first animals. and you can see the tumor very beautifully, or the dye going very beautifully to the tumor. You say, Weiss, what's the deal with the base of the tail there? Well, so we used to shave the animals in preparation for the ICG measuring, but we got careless and we nicked his skin. We disrupted the vasculature, and so now you see the signal. So from this fellow on, we use Nair. So in the laboratory, just like in the operating room, sometimes it's the simple things that save your butt. Now, this is really great. And so we pulled out the mouse lungs, and okay, all those bright dots are metastatic tumor. So now I'm a happy guy. I can see it. I can quantify it objectively. I can compare between experimental groups, and I'm as happy as can be. But the residents and the medical students who were actually doing this work thought that they could see something else. They thought that they could predict, based on the ICG, which animals were going to have a local recurrence. So let's talk for a second about margins, and I apologize for the redundancy if some of you heard this yesterday. It works the same in soft tissue sarcomas. So the actual tumor is the part of the orange that we eat, right? And if I go in there with my melon baller and I scoop out the tumor, no matter how meticulous, no matter how careful I think I'm being, I will leave sarcoma cells behind. It's guaranteed. That is not okay. 100% of these cells got to go. So how do I remove all of the tumor? Well, I put a peel on it, just like the peel on this orange. So I put normal patient in 360 degrees in 3 dimensions all the way around the tumor, thus ensuring that I remove the whole thing. So in soft tissue sarcoma surgery, do we do some intentional collateral damage? The answer is yes. Do we feel bad about it? I don't know about my partners, I feel bad about it. Do we apologize for it? The answer is no. Because in 2025, this is how I know I'm getting all of the tumor out. This concept of negative margins is sort of the guiding principle of sarcoma surgery. But even in the best of hands, local recurrences, which is when the tumor grows back where it was, happen. Local recurrence is a devastating complication. It is correlative with additional surgery, metastasis, the need for additional treatments, amputation, and death. It's really terrible. If you look globally, which obviously we are in this room, the local recurrence rates are between 10 and 30%. And the psychological implications are obviously tremendous to a patient and their advocates. And our failure to make that number better is a really big obstacle to our patients with soft tissue sarcoma. And let's be honest, what can I control and what can I not? When a patient comes into my office, she brings a sarcoma of a certain size, location, and histology that I can do nothing about, right? I get what I get, and whatever walks in the door, that's what I need to look after. The only thing that I can affect as a surgeon is the quality of my margin. Now, you might get me to agree that local recurrences are a part of doing business, they're gonna happen, we will never eliminate them completely. Oh, okay, I might agree to that. I do not accept the hypothesis that after 12 years of training and 15 years in practice, I can't do better than 80%. I don't believe that. So I've got all these residents and medical students in my ear telling me how great ICG is for margins, and I had to get a little salty with them. I said, guys, that's great, but this is not who we are. We are a molecular oncology metastasis laboratory, and it's not that I don't like local recurrence, I hate local recurrence, but I hate other things more. Well, the next thing I know, Adel, who is now Dr. Adel Majoub, a medical student in my lab, went ahead and, with very little help from me, wrote and got a grant to answer precisely this question. Can we use ICG in real time in sarcoma surgery to have less local recurrences? And wouldn't you know, he got the darn thing. So I said, well, okay, I guess now I'm doing some margin science. So this was the experiment that Adel came up with. We had 2 experimental groups, and I'm going to show a picture of this on the next slide so it'll be hopefully more clear. 2 experimental groups of 11 mice apiece. Group 1 has surgery directed by ICG imaging, and group 2 does not. So in the group 1 animals, we do the surgery, and if we see more signal, again, we don't know what that even means. We just know that there's a signal there. We keep cutting until that goes away. In the group 2 animals, we do the surgery the way we do the surgery, and that's that. So this is what that looks like in pictorial form. See, here's the group 1 animal. We made our cut. It looks like there's still stuff there. We don't know what that means, but we're going to cut until the signal goes away. Okay? In the group 2 animals, we make our cut and we're done. So what did Otto find? Well, he found that in the group 1 animals, we had 0 out of 11 local recurrences, and in the group 2 animals, we had 9 out of 11 local recurrences, and we had 100% negative predictive value because the 2 animals that did not recur were predicted to not recur by ICG. So that was pretty interesting. Limitations of this study are many. The first one is bias. Say, come on, Weiss, what are you trying to pull here? You know that you did your best surgery on those group 1 animals and your sloppiest surgery on those group 2 animals just so you could prove your point. If I were reviewing this paper, that's exactly what I would have said. But remember, the point of this study was not to show how good or how sloppy of a mouse sarcoma surgeon I can be. The purpose of the study was to demonstrate if that picture, that signal, is correlative with anything you and me care about clinically, in this case, local recurrence. And we thought the answer was definitely yes. There were other limitations, but despite the many limitations of this study, we felt that we could conclude that ICG signal or its absence reliably predicted the clinical event of local recurrence in our mouse model. And given these observations, it might not be so silly to start looking at it in our patients. My next lab resident, Sumail, and my research coordinator, Alma, said, hey, Weiss, we're going to start a surgical observational trial in a super rare subset of diseases in the middle of a pandemic. And I said, sure you are. But God bless them, they did the work. They jumped through all the regulatory hurdles and did all that stuff, and this is the protocol that we started with. We inject the ICG when the patient comes in the surgical, on the day of surgery in the preoperative area. Now, Kenny Rankin and I disagree about this all the time, and we'll continue to do so, but that's fine. We'll figure out the right way forward. In any case, so patient comes in for surgery, they get their IV, they get their dye. I do the surgery the way I do the surgery, and when the tumor's on the back table, I leave the room and I complete a feedback sheet saying, how do I think the margins were? Let me back up for a second. So what are we using now as margin assessment should be a good question. Right now, it's my eyes and my hands, right? The margin was negative because I thought it looked good and it felt good. It is the most unscientific thing in the world and based entirely on our training and our experience. It's no wonder our local recurrence rate is so high. In any case, so I set this up as kind of a contest that we're going to have what the detector sees and what the surgeon thinks, which is right now the standard of care, and which one's better, right? Which one is going to most closely resemble that final pathology report? Okay. And I'll explain at the end why that was a little bit silly. What we're trying to get at is, does this technology do anything to help the eyes and the hands of an experienced sarcoma surgeon? This is the setup from Stryker endoscopy. There are lots of different systems. This is not the only one. It's just the one I use. This is our very first patient. Now, we worked pretty good in mice. We didn't know if we were going to see anything in people. This is a chest wall soft tissue sarcoma, and it doesn't project great, but where that blue arrow is, there's a little dot that looks different than kind of the rest of it. It ends up that area was a positive margin, and this patient had to go back to the operating room. We went through constant refinement. These papers are from our colleagues in breast cancer surgery. And as we've mentioned a number of times, they have numbers and statistics that we can scarcely dream of in sarcoma. So basically, we bastardized their protocol for our sarcoma patients. And this was championed by my next resident, Bill Lee. And Billy said, okay, we're going to take the tumor out of the patient, and the brightest part we're going to call 100%. So each patient acts as their own positive control. Then we're going to go back to the resection bed, and based on what our friends in breast cancer taught us, any signal that's 77% or greater, we're going to call that concerning for a positive margin. So we did a bunch of cases, between 50 and 60 cases, and then we brought all our numbers to our marvelous Dutch biostatistician and said, here you go, Brenda, what do you think? Now, not to stereotype, but unfortunately for me, the Dutch are not famous for suffering fools, which is a problem for me. But Brenda said, I understand why you guys did this 77% thing, but would you not want to develop, what makes you think that sarcoma is going to work the same as breast cancer? Would you not want to develop sarcoma-specific parameters and a sarcoma-specific protocol for this technology? And we said, well, Brenda, it sounds a lot dumber when you say it. And she said, never mind, you've saved all your videos. Go back to the drawing board, look at all your videos, and see if you can't come up with some sarcoma-specific parameters for your colleagues in sarcoma surgery. So we went back to the drawing board, and by we, I mean my next resident, Clark, who spent a year basically going through all these videos to see if he could come up with some sarcoma-specific parameters of how we could use this tool. And so this is the way it is right now. It may change in the future, but right now this is the way we're doing business. First part is still the same. We take the sarcoma out of the patient and put it on the back table, and the brightest area is called 100%, and we sort of zero it, we tear it. Then we go back to the resection bed, and we do a background calculation. So it's Palm Sunday, so we make the sign of the cross. We look at the brightness of the resection bed, top, bottom, side, side, deep, those 5 points, and we get an average. That's our average background, okay? And so based on that, we kind of scan the whole area, and anything that is 1.5 ratio or higher of the background is concerning for a positive margin. So let's say that our average that we calculated was 10, right? If we are scanning through there and we see anything that's 15 or greater, that is concerning.
Accurately.
So this is what
We
that
look
looks
superiorly,
like in real
inferiorly,
life.
medially,
That's
laterally,
Clark.
and deep at any healthy appearing muscle tissue.
This is
and
a
take an average
radiation.
value.
Can we turn that down? I don't know if we can.
This
If-
man
if
had
we
an
can, it's
average
okay.
value
Thank you.
for a background
So this is
fluorescence
a
of 6%.
radiation-induced sarcoma.
We then
of the
also
thigh
look
that I
at the
took
maximum
out.
fluorescence in the
And,
tumor bed.
We
It's this red
calculated
area
our
here.
background on this guy as
With a
6,
maximum fluorescence
right?
of
So anything
24%.
that's 1.5 times that is
We
concerning for a
then
positive
use these numbers to
margin.
calculate an
And
SBR,
in the middle there, you
or
can see we're up in
signal
the
to background
20s,
ratio.
you know,
24% over
and that-
6%
so that area
gives him
is
an SBR
concerning
of
for a
4.
positive margin.
This is considered an
And it
ICG
turns out that
positive
area
margin.
was positive, and
Anything
this
over
guy had to have no
1.5
surgery too.
is an ICG positive.
So this is our demographics. Some had chemo, some had radiation, some had both. Now, this is probably the most important part of the slide, or of the presentation. So what we found by using Clark's protocol, ICG is very, very sensitive, but not terrifically specific, meaning there are a lot of false positives. The ICG is going to call a lot of things positive that aren't really. Surgeons, on the other hand, aren't terrifically sensitive, what a surprise, but they are very specific. When a surgeon tells you the margin's positive, the margin's positive. Okay? So when we set this thing up, and also the detector was superior to surgeons and pathology actually at predicting a local recurrence. So what are our conclusions? Well, we set the thing up as a contest. We've got this detector and we've got the surgeon. Which one's going to be better at predicting local recurrence and being correlative with the final pathology? Well, that was probably silly. And the reason why is because the detector can see things that my eye can't see, right? But based on my experience, I know things that the detector doesn't know, okay? So remember, the detector's real sensitive, but I'm real specific. So as we move forward, we're writing up this paper right now, but as we move forward with hopefully a multinational, multi-institutional clinical trial, can we put the chocolate with the peanut butter and maximize the best parts of the surgeon and the best parts of the technology to decrease local recurrences in our patients? I think we probably can. Again, thanks for all my funding sources, particularly CTOS and SFA. It's never me, it's always we. And thank God for all these residents and medical students who sort of dragged me down this path that I didn't want to go down in the first place. And it ended up being very exciting. And thank all of you.
Okay, good morning. All right, thank you very much for having me. It's a pleasure and a privilege to be here. My name is Ashleigh Guadagnolo. I am a radiation oncologist. I think that was under the et cetera category earlier. I do exclusively sarcoma and melanoma. I've been doing that for about 20 years, and we treat about 700 patients per year, the majority of which are sarcoma, bone, and soft tissues. So I'm gonna get the slides up. So we can have this be a little more conversational. I did provide some slides for framing. Radiation can get really wonky really quickly. I'm going to talk about, so the topic was innovations, and I think there are two kind of hot topics. One is really the juicy one, which is this issue of do we really need 5-6 weeks of radiation for sarcoma? That's the one I think that patients really want us to answer and answer it correctly. And I think we should talk about that a little bit because we actually really need the patients and the caregivers and the advocacy community to help us answer that question and answer it correctly. I think that what has been missing from that question is what is the patient perspective about trade-offs. And then the last thing I'll talk about a little bit, which may have been touched on yesterday, was this new study of immunotherapy and radiation. And I will not talk so much about the systemic side, but I'll talk a little bit about the radiation side. So I'm an employee of MD Anderson. I have no other conflicts. I don't have any other conflicts to disclose. So let's see, is there a trick here? Did we lose it? Oh, there we go. Okay. So one note, if you just to kind of put it all together, ASTRO actually for the first time commissioned a clinical practice guideline in radiation for treatment of soft tissue sarcoma in adults. I do just adults. The only time I see kids, I do AYA, but the only time I see anyone under 18 is to tell them do not irradiate this desmoid. Occasionally someone will send a patient to me because I have a desmoid practice, and the pediatrics people will say, look, this patient came and can you tell them no? And I say yes. So I don't see kids. But this is a very nice guideline. It's very reasonable. There is an executive summary that has been published, but there's also on the ASTRO website, there is a very sort of clearly written guideline to how we manage it. So I'm going to just refer you to that because it's just easier to start there. So the first key question, just kind of for the basics, is what are the roles and indications for radiation in the treatment? In all of these boxes that we answered these key questions, the first thing was really a multidisciplinary evaluation at a sarcoma center, expert center, really is recommended. But the main thing for what I do is that when surgery is planned for a resectable sarcoma, when there is an increased risk for local recurrence after the surgery, we strongly recommended that radiation be considered. And just a review, the assessment of local recurrence, as we just heard, can be somewhat complex, and it can involve multiple factors. One of them can be, even in low-grade tumors, if you would need to have another big surgery to fix a recurrence, you probably should consider radiation up front. The evidence that supports this recommendation is quite high. A non-exhaustive list of factors, there's the surgical margin status, which we've heard quite elegantly a lot about. Tumor grade, it's most associated with metastatic risk, but it can be associated with local recurrence risk. Also, as you know, there are 60 plus types of sarcomas depending on who you ask, and the type of sarcoma can influence recurrence risk. The size and the anatomic site, which kind of indirectly influence radiation recommendations via margin status, and then again, the morbidity of a potential salvage surgery. So the next big thing, and this is a little bit subject to practice patterns culturally wherever you live, but do we do the radiation first or do we do the radiation second? And there is a landmark trial that was done in Canada, and I'm going to give you the name because I'm going to refer to it again, the NCIC SR2 study, which studied this question specifically. And it actually, we recommend at most consensus centers that if you can, to do the radiation preoperatively based on that study. So it was a strong recommendation, but it is a little bit controversial because there are many surgeons who just aren't comfortable going after radiation. And the reason why we're comfortable recommending pre-op radiation over post-op radiation is because the outcomes in that trial were equivalent. So whether you did the radiation first or second did not matter for tumor control. It's the same, very high rates of local control. And so they have very good long-term follow-up. And every other subsequent study, big registry studies, single institution, there was one that we did that was over 400 patients. These rates are stable. If you do it pre-op or post-op, it doesn't actually influence the oncologic outcome. The preference for pre-op radiation is driven by the permanence of side effects, okay? So when you do preoperative radiation, it's a lower dose. It's a standard of 50 gray in 25 fractions, so about 5 weeks, and we'll get to that in a minute. It's a smaller volume because you treat the tumor plus a margin. But it is worth noting that the acute wound complication rate after that surgery, or the major wound complication rate, is higher when you do radiation first, because when you irradiate a tissue and then do surgery, it does not heal as quickly. And so some of those complications are non-trivial, right? So reoperations, wound vacs, drains, hospitalization, reoperation. So non-trivial, but they're usually reversible. So once they're fixed, they're fixed. When you do post-operative radiation, you've committed to 6 weeks of radiation post-operatively, so 60 gray, so a higher dose. If the margins are positive, then it's an even higher dose. And we do not just where the tumor was, but we do the tumor was plus the surgically handled tissues, right? Because the worry is that those are at risk. So it's a bigger margin and then a margin on top of that. So it's a much larger volume. And what the NCIC SR2 study found, they did a very nice long-term follow-up study that showed that the patients who had post-op had more edema, fibrosis or scarring and density of the tissues, and decreased range of motion at the joint. And that was permanent, and in some cases progressive, and function limiting, right? So it interfered with function. The other thing that they didn't specifically address in that particular study, but have done so very expertly with subsequent studies, is fracture risk. So when you do a higher dose to particularly weight-bearing bone, there is a risk of fracture. And those are usually irreversible. So for that reason, we recommend pre-op. So I'm gonna talk about hypofractionation, which is the shorter courses of treatment in the setting of pre-op radiation for 2 reasons. One, that's kind of where we lean. And 2, there really hasn't been any work done on using shorter courses in the post-operative setting. I think we'll get there, and there is a study kind of on deck that we're hoping to see results from in a couple of years that's being done in Canada. It's called the Upfront Out Back, and they're looking at whether the 50 gray pre-op dose would be effective post-op, and if that gets answered, I think we'll move into a whole new debate about whether we can shorten the course post-op, but we're not there yet. So we're gonna talk about pre-op radiation, and can we do it faster than 5 weeks? So the big question is still one size fits all? Is it 50 and 25? There have been a number of studies in breast cancer, rectal cancer, prostate cancer, where they've gone from 5 weeks or 6 weeks to 3 weeks. And even in breast cancer now with the UK Fast Forward, they've actually gone from 3 weeks to 1 week. So that's really the big question. This is a busy slide, and I'm not gonna read it all to you, but in sarcoma, the current state of the debate about whether or not we can shorten the course of treatment for sarcoma patients is based on a series of phase 2 studies. And in the top darker light blue, if you will, box, those are what we call ultra hypofractionated, where they've really increased the daily dose of treatment, and they've condensed the treatment down to 1 week. And then we have published, and then Mayo is actually, I think, imminently going to publish their experience on a moderately hypofractionated course, which is 3 weeks of treatment. So it's increasing the daily dose, but kind of in a middle way, if you will. And just a reminder, the benchmarking local control for extremity and superficial trunk sarcoma treated with combined radiation and surgery is 85 to 95% in good hands. So we can actually, this is where it gets a little in the weeds. So we can actually take the studies, and we can try to, how do we compare these doses? There is a formula that we use. It is not linear, so it's not just a simple matter of taking the 50 gray and dividing it by the number of days. It's a little more complex than that. And there is a derivative of that formula that can allow us to standardize these doses to the same 2 gray per day thinking. So what is the 50 gray equivalent or the 2 gray per day equivalent? We call that the EQD2. And that is tagged to one index to help you understand what your target is. And obviously, we're worried about tumor control. And so the number, it's called the alpha beta, which is how we index that to thinking about what our outcome of interest is for sarcoma is 4. When you think about late effects to bone, wound healing, scarring, that number is lower. The number is likely in the 2 range, and that's based on some data largely in the breast cancer literature. There isn't good empirical data for sarcoma, but I think that that's a good number. And the thing to know is that when you decrease the alpha beta and you increase the daily fraction size, you increase the dose effect dramatically. And that's shown here. So across the top, you can see the EQD2 for tumor control, which is 4. And if I take the current standard as 50 and I take the various regimens that have been studied in a phase 2 setting, you can see that when you do 5 gray per day instead of 2 gray, that the dose is a little bit lower if you do it in 5 fractions. But once you get to 5 fractions at 6, 7, 8 gray, the dose starts to go up dramatically. And then the moderate course is right at 49 gray. Now going to the bottom, looking at if you do that calculation for the outcome of complications, and you can see at 6 gray per day and above for these 1-week regimens, as you increase the daily dose of the daily fraction size, the dose effects to these late tissues goes up quite dramatically. And in the case of 8 gray per day, it's actually double. And so I think when we are thinking about this, this is the math. But one thing to know is that biology is not equal to math. And so much of the data used to generate the model that we radiation oncologists use to do dose, a lot of it is from cell culture experiments. You can empirically derive this alpha beta for clinical outcomes, but it takes a study and it takes infrastructure, and it hasn't really been done for sarcoma. It needs to be done for fracture and for fibrosis and wound healing. That's one of the things we need to do, but it doesn't exist. So we have to extrapolate from the cell culture and from some other experiences. And there is some observed disconnect between the model's predictions and the observed in vivo effects, meaning what happens really in patients at higher doses per fraction. That model breaks down a little bit. And this is particularly true when it comes to vascular and stromal tissue damage, which is very important for sarcoma patients who often have very large tumors that have very big surgeries and wound healing issues. Okay, this is a busy slide. And so this is all to tell you. What I'm going to tell you here is, you can look at this curve. So basically a bunch of experts, a lot of our friends, got together and they took the sort of compendium of historical hypofractionation or shorter than 5-week regimens, about 16 to 20 studies, and they plotted out, they standardized them back to this 2 gray per day so that they could compare them all as though they were the same daily fraction size. And they plotted them out in this curve. And so they did 2 curves. So I'm going to focus your attention on the black curve. And in the black curve, the y-axis is local failures, and on the bottom is dose. And what you see is that for tumor control probability, it plateaus just under 50 gray, right? So there doesn't seem to be a tumor control benefit when you do preoperative radiation and have a good surgeon go in and take it out. It doesn't seem to be a benefit to dose escalation beyond 49 to 50 gray. Okay. So again, I'm going to show you this table, which I showed you a minute ago. And now what I've done is I've added in the local control values, and it shows that here for these various regimens, both the 4 1-week regimens in the middle and the 3-week regimen on the far right. You can see that if your equivalent dose is less than 50 gray, which is the 5 times 5 gray, which is really based on 2 really well-executed studies by the Polar Sarcoma Study Group, that if you're below the 50 gray, that the local control rate is really below what our historical standards, which I think the floor is really 85 to 90%. And so most in the US, Canada, and I think Western Europe have not adopted 5 times 5 gray. The nice thing about that regimen is you can see that the complication dose is less, is that the complication risk is lower, and that has borne out in their studies. But if you get to 50 gray and above, then your local control is in the green there, and it's quite good. The SR2 trial, which I mentioned earlier, they focused on 3 long-term toxicities, and that is this fibrosis, edema, and joint stiffness, which are very important, and they have function implications. And this is a busy slide, and I'm not going to belabor it other than to say that the SR2 study was done in the pre-IMRT era, so our techniques are fancier and more conformal. And so the rates of these complications were actually a little bit higher than all of the modern studies of hypofractionation. And so what's happening is people are doing these studies, and we did it as well with wound complications, and they're using the SR2 complication benchmarks, and they're saying, okay, it's fine. And what I would like the patient community to know is I think there are 3 things that we need to think about before we sign off and say that this is fine. And so we need your help to understand what we're a little bit worried about, and for those of us who do this. So there's caution going forward with this. If you focus only on acute major wound complications, which we did in our study, all right, that was what we used as our primary endpoint, and at 3 weeks, fine. It does not increase the wound complication rate. And all of the phase 2 studies also looked at that. And you know what? If you're doing a alpha beta that is close to 50 to get you a dose that's close to 50 gray, if you're using your calculation, then indeed your wound complication rate is fine. And then most of the studies have commented, and including, I think, some proposed studies in the pipeline to study this as a secondary endpoint, this SR2 triad, and it's also going to be fine. So local control is going to be fine because the dose that you're picking is equivalent to 50 gray, right? So you're not changing the dose to tumor. What you're actually studying is toxicity if you increase the daily fraction size. And so these are going to be fine, but I think it overlooks 3 things that have signaled in this literature that I think we need to systematically study before we leap off and do this as standard. The first one is amputations. So the point of someone like Dr. Weiss and myself treating a patient is to make sure that we don't need to amputate the limb. We don't need to do that anymore. There are good studies that show that with combined modality therapy, you don't need to remove a limb. In all of these studies, and now they're listed vertically down, an increasing dose in the blue for the 1-week regimens, and then ours at the bottom. If you look in the middle there, where it says any amputation, what you start to see is, I don't know if can you point here? What you start to see is that the amputation rate is going up as the daily fraction size goes up. And then what I would say to you is that sometimes a patient does require an amputation. They have a local recurrence, and to save their life, we need to do an amputation, and that's completely valid. And so you see that at the top of the table here in that second to the last column, where you're seeing a 3 to 5% amputation rate. I've spoken to those authors. Those are all for local recurrence. What you also see on the far right-hand side is as you increase the daily fraction size, you start to see amputations for complications. So this is not for local recurrence. This is for fractures, persistent infections. In that study from 2021, that's 5 times 8, that was from the University of Sao Paulo. They had 4 amputations for complications. So that was a 16% amputation rate in 25. It was vascular occlusion of the flap. They had 1 that the joint toxicity was so bad that it required an amputation. You never see that with the 5-week regimen. I've been doing this 20 years. I've never seen a patient require an amputation for 50 and 25. So I think we need to make sure we understand what's going on here, because this would be a new development to need to amputate patients for a complication. So that's the first thing. All right, this is also, sorry for the wonk. So the second thing is wounds close at 180 days. So a 1-week course of treatment would indeed be much more convenient. However, if you have a wound that's open that needs to be dressed for 6 months beyond, that's not more convenient. So we need to look at this for a second. So in the Netherlands, this group does such great work. So they actually took 191 patients who got 25 times 2 gray, so the 5-week regimen, and they plotted out how many days their wound was open. This is a great study. And what they found that 9 of 191, so 5% of patients did not have a wound healed at 180 days. And we see that sometimes patients with diabetes, smokers, vascular issues, is what the population that we usually see this in. So, but it's 5% for the current standard. In the first, and this group at UCLA has done a terrific job documenting their study. They actually didn't comment on the text, but they provided a very nice table or graph, I guess, a bar graph here. And they plotted the time to wound closure, and if you drop a line at 180 days, 7 of 50 patients did not have their wound closed at 6 months after surgery. That's 14% of the cohort. They recently updated this at ASTRO last fall, and the first author reported that their new rate of open wounds at 6 months is 16%. So that's 3 times the rate for 5 weeks. So I think we need to understand what's going on there, because that while it may be more convenient to get 1 week of treatment, I would probably posit that it's not more convenient to have a wound that needs to be dressed for 6 months. All right, the last one is bone toxicity. And so in SR2, they didn't comment on this, but the Canadians, they have such a great database. They have published, they had about 600, 700 patients, and the bone fracture rate for weight-bearing bones is really what we're most concerned about, but we'll get to that in a minute. It was about 4 or 5%. And we had a several hundred patient database study, which was about the same. So anywhere from 4 to 6% is the bone fracture rate. Sometimes you can't avoid the bone, right? These can be very large. They wrap around the femur, and you can talk to your orthopedic and ask them to do a prophylactic procedure, but sometimes the bone is just in the field. So the issue is that they published also metrics of how do you mitigate the risk of fracture. So this is what we all use when we put in a radiation plan and how we do it. And one I would point out is down at the bottom in orange. You want to keep the bone max dose to 59 gray or less. Now that's below the pre-op dose, but let's, for argument's sake, that is a good place to index this discussion. So the EQD2 for bone fracture, we don't have a sarcoma-derived one, but in the breast cancer literature, they have done it for spontaneous rib fracture, and the EQD2 calculation can be indexed to the alpha beta of 1.8 to 2.8, which was what they estimated. For weight bearing, I would probably say it's on the lower end. And again, remember, as the alpha beta goes down and your fraction size goes up, the dose effects goes up. And so I've shown a little arrow to illustrate that. And you can see that for the 5 times 6 gray, which is the big regimen we're starting to see in practice in the US, that at the lower end of the alpha beta in that calculation, the prescription dose exceeds the bone dose. And if you look over to the toxicity corresponding data, they have reported a 5% fracture rate, and they updated this at CTOS, and all of those were in the upper extremity. So they had an osteonecrosis and 3 fractures. I have to tell you, I've never seen an upper extremity fracture from 50 and 25. So that was kind of interesting. These are non-weight bearing bones. You're seeing grade 3 bone toxicity. Even in our study, in the 3-week regimen, which was moderately hypofractionated, we saw 4 fractures eventually out of 60 who had femur irradiation, which is in the 6 to 7% range. That's a little higher than we would have liked to see it. Now, we were using a carbon nail that the orthopedics people thought was a culprit, but we scored them as radiation fractures. But I actually think for both the 3-week and the 1-week, I think more work needs to be done to understand what the fracture implications are for shortening the course, because the bone doesn't tolerate that higher daily dose as well. So those are the 3 things. This is a busy slide that puts all of that together and just again shows that math at the top, and then as you go to the bottom, in the middle there, I put in red sort of what I think is kind of the question mark signals that we need to think about a little bit and that needs to be studied systematically before we move very quickly. And it is happening here in the US. We're seeing people go to a 1-week regimen, and we use the 3-week regimen sometimes off trial, but not as standard. And we always have this discussion about what we don't know. And I think the most important thing I would say to this group who's going to hopefully be participating in some of these study developments and discussions is let's make sure that these 3 things also get incorporated into any sort of trials or studies that look at these shorter courses, because it's not enough to just do wound complications and the SR2 triad. I mean, certainly local control, hopefully the doses are being chosen for optimal local control. So that's it for hypofractionation, and I'm happy to discuss that further if we have time. The last thing is the recent study, the Stand Up to Cancer SARC-32 study of radiation preoperatively versus radiation and pembrolizumab. So immune checkpoint inhibition plus radiation, and their primary endpoint was disease-free survival. It was a tour de force study. It was 20 centers. As I'm sure you've been talked about, it's very hard to do sarcoma studies, and they did a great job with this. It had good follow-up. It was published last fall. This is, they said it was grade 2 or 3 UPS and D-diff lipo, but it's worth the fine print as a patient and as a caregiver and advocate, that there actually was a number of these synonyms. So it's worth, in talking to physicians and patients, and, there was a little bit of a laundry list, because sarcomas can have a lot of words in the path report, and here was some of them they included. So it wasn't just UPS or D-diff or pleomorphic lipo. It was those things, but kind of, these synonyms that we use. The take home is that there was a 15% disease-free survival advantage among the patients who got concurrent radiotherapy and then adjuvant pembro for quite some time. I think the discussion, which is outside of my expertise about whether you need another, 14 cycles of pembrolizumab, but that was how the study was designed. And so you can see this nice separation of the curve. The blue line is the experimental group. They had a better disease-free survival, and it was a pretty interesting signal. So it was a 15% advantage. There was more toxicity in the pembrolizumab group, as you can imagine. So grade 3-4 toxicity was 56% versus 31% in those who didn't get pembro. There was no significant difference in major wound complications, and there was no significant difference in local recurrence. I think just briefly about the radiation piece on that, I think there's a lot of good focus and important focus on whether or not that's the right systemic regimen, whether it needs to be compared to doxorubicin, and how those all need to be, included. But I do think radiation is an important piece. So Radiation helps present the tumor antigen to the immune system and prime it so that the immune therapy regimens work. So that's why radiation is an important part of this study and in the studies going forward. I think the next questions a lot of people have is, well, if we did it for 5 weeks, can we do it for 1 or 3 weeks? And we don't know. That's a good question, and that's sort of the frontier of how we're going to do this. And so I'll stop there, and thank you very much.
Okay, thank you very much for your presentations. Now we have time for questions. No? Oh, yes.
Hi, thank you. I had a question for Dr. Dombi, and I appreciate all the talks and all the speakers. My question is, there was a reference to tumor density and volume, and I wanted to know if there was a difference between the two when you were referencing them.
So tumor density is based on the absorption of radiation through the CT. And when I measure volume, as I was showing, it is circling the tumor and measuring the mass in milliliters. So one is the absorption and one is milliliters.
Okay, thank you. And then I also had a question for Dr. Weiss. You were talking about soft tissue sarcoma, and I know us in the desmoid world, we often, even though we're not technically a true sarcoma, we often identify as sarcoma. And then in the conference, I'm seeing soft tissue sarcoma and then desmoid separate. When you refer to soft tissue sarcoma, are you including desmoid?
So, I would 1,000,000% include someone with desmoid in the study we're doing. I would not, these days, knowing what I know, I would not offer a desmoid patient the opportunity to participate in this study. So the pendulum has shifted a lot on desmoid, hasn't it? Like when my senior partner, Dr. Goodman, was in his heyday, you not only operated on desmoid every time, but you went big every time because you knew you're talking about a tumor that has a higher local recurrence rate than any sarcoma. These days, we kind of pump the brakes and do an observational trial, as you know. But if the thing was just growing before my eyes and I had no choice, I would 1,000,000% offer that patient ICG. Does that answer your question?
It does. Thank you.
This is a radiation oncology question. In our location, one of the institutions has a combination radiation therapy MRI unit, one does not. When you present data from different institutions, are you controlling for that type of technical difference?
We're not. I will tell you that even if you don't have an MRI-based simulator or LINAC, the way it works now is actually we can fuse a diagnostic MRI with CT, and so you don't lose anything by not having an MRI. It's a logistical step that you don't need to do if you do have an MRI. It's a little more complex than that, but I will tell you at MD Anderson, we do have an MR sim and LINAC. We use the MR sim sometimes, but we almost never use the MR LINAC because there are geometric limitations to those machines. They have size limitations. Sarcomas are big. We can't get them in there. We can't do them feet first. We can't have them positioned to get the other leg out of the way. So we don't use the treatment-based MR linear accelerator. We do sometimes use the sim, but when we don't use the sim, we just import the MRI and they can fuse it perfectly, usually, or at least close to perfectly, to the CT-based simulation. So the short answer is no. The long answer is it may not matter all that much.
Another question? Or?
A question for Dr. Weiss. How does preoperative chemotherapy and radiotherapy affect ICG effectiveness?
So that is an awesome question, and I'm not at a meeting where I discuss this where I don't get asked that question. And the quick answer is, I don't know. So based on what we know so far, again, about 55 patients, thus far, it doesn't seem to matter, but we've got to, and this is why my plea is for a bigger study that's going to look at, people who got pre-op versus post-op, all different histologies, so that we can figure out how and when to use this tool and if it helps, so that we can answer your question, because I would also like to know the answer to that.
Thank you for your presentations. My question is for either Dr. Guadagnolo or Dr. Weiss. I think I heard you were saying with local recurrence, you prefer to do radiation. When do you think about surgery for local recurrence, or how do you decide which way you go?
So to reduce local recurrence, we use pre-op radiation when we can, and then post-op radiation when pre-op is either not a good idea or not an option. For local recurrence, I'll just speak to the radiation piece. If there has already been irradiation, we often don't recommend re-irradiation. What we found is that when you do re-irradiation for a locally recurrent sarcoma, the local control rate is 50%, so coin toss. But the risk of a severe grade 3, 4 greater, bone fracture, necrosis, soft tissue is about 80%. And that's a little bit different than the carcinoma experience. It gets talked about a lot, right? Carcinomas are a little more sensitive, so breast cancer, colon cancer, lung cancer, whatever. The issue is that you can't meaningfully give enough dose to sarcoma in a re-irradiation setting safely.
So I think that's a great question too. My life is certainly a lot easier than Ashleigh's is, because she can't just give all the radiation she wants, right? Or else she runs into really big toxicity problems. For me, if I can operate on a local recurrence, I will. But even for me, there's only so many times I can go to the well before just anatomically it's not feasible, and now we're talking about amputation.
I have a question about, we've been talking about patient-partnered research over the last few days in engagement, and Dr. Guadagnolo, you mentioned about how important it is to bring the voice of the patient to the studies. Do you see your community being more engaging of patient advocates and patients when they're planning studies, or what can we do as a community to make sure that we lend our voice and our perspective as these are designed?
Well, I think just visibility. You guys have done a good job with visibility here and at CTOS, and I think more of that, I think is key. I mean, it allowed me to have access to some of you when we were trying to get a study going. We know we need that to happen, but I didn't put it in this slide. There's a study of, so in the US, this shorter course is diffusing very rapidly. For those of you who are not US based, in the US, you don't need to go through guidelines committees and nationalize whatever. People can kind of do a thing. And there was a study on the West Coast of, it was 70 or 80, mostly US-based radiation oncologists, surgeons, and some orthopedics. There wasn't very few Canadians and Europeans. And they did a study and they said, okay, how many of you would accept that 1 week of radiation is fine over the 5-week standard? And it was like 20%. It was a pretty big number for not having any phase 3 data. And then there was a subsequent question that was like, how many of you would accept it even if the long-term side effects were worse than the SR2? And it was still like it was like 19%. No one asked the patients, right? It was all providers, right? They said, oh, it's fine, we would accept that. And it's like, well, would the patients accept that? Would the patients accept less functional, mobility for a shorter course in the beginning? I mean, maybe, but we don't know that, right? And so I think that's important because some of those trade-offs are serious. And so I think, you guys were very helpful. I think we just, we need to do better at realizing we need to loop you guys in to write these studies. I think helping with some of these, accessing patients to give some trade-offs, one logistical piece is when we write a study, the impulse is, well, you have a study cohort that you're doing a trial with, and we're gonna ask them a bunch of survey questions. Well, now you have cancer patients that are coming in every day, and they've got all this stuff going on, and now you want to ask them a 20-thing survey. And yes, that's relevant because they're getting treated, but maybe we need to ask a survivor community kind of what their perspective is, or maybe we need to have access to maybe people who aren't going through the rigors of cancer treatment to ask them a bunch of study questions. So some things like that, and I think you all can guide us sometimes maybe better than we are in the thick of it, applying for grants and writing protocols and things like that. So I think just being available and guiding us when we have these ideas and say, hey, have you thought about doing it this way? I think that's very helpful, and I deeply appreciate you helping. We haven't gotten a study funded, but it's been helpful to think about the study as we've tried.
Am I allowed to ask a question of my colleagues? Okay, so I got one for each of you. Thank you. Those were both amazing presentations. For Eva, deciding when to pull the trigger on surgery on a neurofibroma or a plexiform neurofibroma on a patient with NF is among the most frustrating things, that we do. So I guess my question is, when I'm thinking about biopsy, how heterogeneous are these lesions? In other words, in chondrosarcoma is notorious for this, right? If you biopsy one part of the tumor, it looks completely harmless. Another part of the tumor can look like a little piece of hell. So does plexiform neurofibroma do that? And if it does, that's just added to my list of things that give me anxiety. And my question for Ashleigh, and you pointed this out pretty clearly, that my real education was from your talk here today was that hypofractionation means different stuff to different people. And I guess I didn't appreciate that. And that makes it real hard to study. So in your community, how do you crack that nut? So those are my questions.
Thank you for the question. It's truly a problem for NF-related tumors because of their size. So when it comes to biopsy, the biggest risk for missing malignancy is actually not finding the highest grade portion of the tumor. And we oftentimes do PET scan to guide, because that's suggesting where the highly cellular areas are. But in the examples that I was showing, even the heterogeneous tumors that have focal increase in some of the areas, you do not know if those are really the most problematic portions, and PET scan is not directly related where the highest grade is. We had just one patient where in a football-sized tumor, we found diffusion restriction in a very small focal area and PAT avidity all over the place. So the biopsy was successfully guided to the diffusion restricted area and proved to be malignancy. This patient was able to undergo surgery, which is almost like a miracle. So I do believe that diffusion-weighted imaging is very powerful in detecting the most concerning portion of the tumor. The problem is it's a finicky imaging technique. It doesn't apply where you have metal in the neighborhood, so you miss a lot of the information in some of the scans. But it's one of the biggest questions in imaging for this condition.
With respect to hypofractionation, I'll try to make this somewhat simple. There is moderate or just hypofractionation, and then there is ultra hypofractionation. Moderate hypofractionation is greater than 2.2 gray per day and less than 5, so up to 4.99. If it's 5 or greater per day, it's ultra hypofractionation. And that has to do with when you get to 5 gray per day or greater, then you start to see some breakdown of that model in the linear quadratic equation that we use to calculate dose. So ultra hypofractionation for sarcoma, you can think that's been these 1-week regimens. And then moderate hypofractionation is 3 weeks. The Netherlands has a 14 fraction that's very similar to ours, and it's a moderate hypofractionation. And so that's the 2 basic bins. And then within ultra hypofractionation, I think it's worth, as someone who's thinking about studies and reviewing papers and things, how high is that daily dose? And I think over 6 gray per day, I think this phase 2 studies show that then you start to run into real problems. And as that curve showed, it doesn't get you anything, right? You don't get better control once you get over 50-ish gray, right? And so in the US, the 2 regimens that are diffusing very rapidly is the 5 times 6 gray per day. and then the 3-week regimen that you're seeing, the 2.85, and then in the Netherlands case, it's 3 gray per day.
Another question or comment? I have a question for you, Dr. Weiss, because you said that you had a lot of, sorry, I forgot my false positives. I'm sorry if I didn't get it, but what are the signs of these false positive and how do you deal with this?
Okay, so it's a good question. The detector had a lot of false positives, right? Because it's super sensitive, because it works better than a human eyeball. And the way that I think we can mitigate that is by adding the surgeon's experience. So in other words, I'm scanning the area and there's a part way out on the periphery that is above my SBR of 1.5. And I say, forget about that. We don't need to worry about that. We're a mile away from the tumor, it's fine. Whereas the same number right on, close to the femoral vessel, I felt like I was getting close there. Maybe I need to send a frozen. Maybe I need to do something else. Maybe I need to call my partners in vascular surgery, right? So moving forward, I would like to figure out the best way to combine the strengths of the human and the strengths of the detector, and maybe that will be a way that we can diminish local recurrences.
Thank you very much.
Thanks, Estelle. I'm wondering, Dr. Dombi, we've talked about several studies in sarcoma that haven't met their endpoint, and then therapies not moving forward. And some of the speculation has been, have we used the right tools to measure benefit? And so as I was listening to you talk, are these kind of coming down a path so that we are getting closer to be able to standardize those techniques that you've talked about that are emerging, that we might be able to measure better benefit and maybe identify more opportunities for better therapies for patients?
Excellent question. I can speak from the perspective of neurofibromatosis. This research group actually created an effort to standardize clinical trial outcomes. It's called response evaluation in neurofibromatosis and schwannomatosis, with the exact goal to bring the research community to the table and agree. It involves patients' input, that they can say, this is important for me, as we heard from the radiation perspective, and it involves the experts who can say, this is something we can do consistently, and we come to a consensus and agreement, and these guidelines are then published. Each specific tumor type has, like in a rare disease, very different needs, and it's a small community, but it has to agree. There has to be a standard, so trials need to be comparable, and you cannot say that for this specific treatment, for this specific tumor, I choose to do this. It has to be supported with evidence, but the evidence comes from people who understand the disease. It's good to have more than one perspective. It's always better to involve the surgeon, involve the oncologist, involve different disciplines and the patients to arrive to something that is meaningful, consistently measurable, and then move forward. Thank you for bringing this up.
No more questions or comments? Okay, so I think we are right on time for the coffee break. I would like to thank our 3 speakers. Thank you.